beamed. Good morning, everyone. Welcome to our quarterly visiting professor rounds. It's a great pleasure for me today to introduce Tony Senagore, who is a very well-known, I think the term is a key opinion leader or thought leader in colorectal surgery. Although Tony has been around the United States and worked in a number of institutions, it's fair to say that he's a Michigan boy and always ends up back in Michigan, where he is now as a professor of surgery. Tony did his residency in Michigan and before faculty stays in the Cleveland Clinic for 7 years. 7 years.
7 years, yep.
And then spending some time in Ohio, USC, and most recently Galveston before returning to Michigan. Tony has had a very prominent career in the field of colorectal surgery, culminating in being elected president of the American Society of Colon Rectal Surgery, and subsequently served as president of the foundation board. He has wide-ranging interests in colorectal surgery, inflammatory bowel disease, colorectal cancer, but also has a very specific and detailed knowledge and interest in the business metrics of surgery, and particularly value-based purchasing. And of course, as part of that, he completed an MBA. Today, he's going to speak to us on a topic close to our heart. Tony has published over 200 papers over the years, and numerous of these papers are on the topic of enhanced recovery after any form of surgery or fast-track surgery, or as it's often called now, enhanced recovery pathways. So I'm very grateful for him, and we're honored to have him here today, and I'm looking forward to his talk. Tony?
Thank you very much, Dr. Monson. It's great to be here, definitely to be out of the cold. So I think we're somewhere in the queues right now in terms of storms coming through the north. So that means we're almost going to cycle through the alphabet, unfortunately. What I'm going to speak to today is what I think are some of the newer things in enhanced recovery, and what I think should be pretty standard. And really, the only new difference between colorectal surgery, which is what I do, and everybody else, is the bowel prep. Everything else, honestly, should transfer. Maybe some little nuances between specialties in terms of regional blocks and some other applications, but everything else really applies. And it's amazing how confused what I think is fairly simple topic gets when people don't actually read all of the data that's available. So these are my disclosures. So I'm going to focus this on colectomy because it's what I do a fair bit of, but you could use the same approach for any of your specialties. So these are the four most common sources of complications in colectomy. No mystery of why they are. This is the financial impact. So this is the money that stands to be gained if you are running a business. It's hard to have this discussion sometimes in medicine because we aren't really structured to think that way of a cost of a resource and what is the return on that investment. Everybody sort of forgets these costs that go away, but this is actually dollars that if you didn't have to spend would be available for other healthcare activities. So if you can spend less than that number to prevent it, that's a winning strategy. Sometimes we do crazy things in medicine, like you probably have a CAUTI team like the rest of us, for honestly something that would never pass the financial muster. The true cost of a CAUTI really is almost nothing. You couldn't even come up with a number to do it. But it's easy to measure, easy to punish, has created a lot of work by CMS, and probably diverted a lot of money from real healthcare improvement. This is the other thing I think to kind of remember is that the cost of a colectomy, ileus is the #1 complication that we see across all of pattern. Now, it's less than laparoscopic, and it's less the less narcotic you use, because most of this is narcotic-induced. But if you do an open surgery or surgeries that consume a lot of narcotics, you're going to have an ileus rate that costs money. And in this population, even with an enhanced recovery program, 40% of the cost of managing the population was due to ileus. Even with an effective strategy for prevention, try to mitigate the incidence, still, fortunately, because we didn't have a lot of other bad things happen, this was really a significant source of cost. So let's talk about what I think are the potentially new components, and I'll try to highlight what I think is standard. So some of thinking now, because we're really around the margins in enhanced recovery, right? We've gotten about 75% of improvement by just doing minimally invasive, trying to do some easy things around pain management. But when you're now tweaking for that last 3, 7, 8% of improvement, you're down in the weeds looking at some things that we don't normally think about. One of the things in colorectal surgery that we often forget, and actually orthopedic surgery, it's almost more common, is pre-existing anemia, which is mostly iron deficiency in folks over 50. We have established now, at a couple places I've been, a pre-op anemia clinic. So we have when we see the patient and we're going to schedule a procedure, we draw a CBC. It reflexes to appropriate studies based on the CBC. If the MCV is low, it reflexes to iron studies. If those studies come back positive, we have a reflex order that sends them to the infusion center for an iron infusion. You get that now in about 3 weeks before, you can dramatically decrease your transfusion rate, which comes back to you not only in terms of hospital cost for the transfusion, but reduction in complications like trolley, like SSI, and other issues that are negatively impacted by transfusion. Immunonutrition, I'm going to go through some data. This, I think, is a reasonably confused area because the science of 2019 is a lot different than the information that is often quoted from when I was a resident. So a lot of the studies that are propagating various approaches came from the 70s and 80s, even before I was in surgery, and things have evolved in terms of the science. Talk about the carb loading and also some maybe a more advanced strategy of thinking about analgesics, and then talk about goal-directed therapy. What I don't think is new is oral mechanical bowel prep in colorectal surgery. I think we've gone full circle from Nichols Condon originally being right. They did every permutation of the study that's been done subsequently. The problem is we got a little speed bump by studies being done incompletely, and I'll show you some of that data. The rest of this, I think, is pretty much mom and apple pie. These are all standard things that we do on a regular basis. Interestingly, early ambulation is probably one of the hardest things to actually pull off at a system. One strategy that I found to be very effective is we just created a walker program. We have people whose only job in life is to help people walk. We don't depend on the nurses. We don't depend on physical therapy consults. We have a team that that's their only gig every day is to get people up at least 3 times a day, and they just circle through the unit. To show you how bowel prep has evolved, this would have been the thing I would have done when I was a PG1. And you can see this is a lot harsher than what we ever contemplate today. And yes, if you remember this kind of bowel prep, there are a lot of downsides to doing it. But I haven't done this ever in practice. So this all went away long ago in terms of a really structured 3-day harsh prep. So when you look at no prep and mechanical bowel prep for I don't know if there's any trauma surgeons in the room, but we all learned in trauma that really there was never a risk to healing the anastomosis if it was unprepped. We were just willing to accept the SSI after the gunshot wound. And that's really all Nichols and Condon ever said from their bowel prep data is it decreased surgical site infection. It got extrapolated over a large number of years that it meant you couldn't do an anastomosis, it wasn't safe, there was going to be a leak rate. None of that was ever data that came out of their work. That all just got mismanaged over time, and I think grew to really be a big, scary thing. And I think probably still exists today in a lot of places that people are unhappy about doing an anastomosis. The trauma surgeons, I think, already figured this out. But for the non-trauma general surgeons, sometimes that can be a speed bump. But when you look at the data, and this is the problem when you look at the no prep data, the no prep data always compared, at least recent times, to a mechanical bowel prep. Nichols and Condon proved that just a mechanical bowel prep without oral antibiotics made no difference. That was their original work. So shockingly, we proved the same thing in the 2000s, and somehow everybody said that was a great idea, that no prep and a prep were equal. Everybody forgot the fact that it was the oral antibiotics that were the effective component. And this is just data showing about adding oral antibiotics. And the data is consistent. Small series, case series, single institution, non-randomized, randomized studies. Always the winner is the combination of oral antibiotics and a mechanical bowel prep in terms of SSI. Maybe leak rate, but I'm not sure I would go to the mat on that one. But certainly for SSI, that's true. So again, just to show you, you need to read the paper. This was actually the original one. In today's world, this would be considered underpowered and be all kinds of issues about that. But in their era, it was a pretty solid paper. But their conclusion was the same thing, that it was the oral antibiotics that made the difference. And somehow that got lost in translation through the decades. So one of the things I did switch when Medicare let me be a doctor again and got rid of the mandates for certain antibiotics or specific antibiotics. It went back and said, what's cost effective and works? So I switched back to Ceftriaxone. It's a cheap antibiotic, so $1.50. It's one dose for the day versus Ertapenem, which still I think is around $85 a dose. So yes, they're both one-time shots, but now I have about $80 to play with in my enhanced recovery program because of the cost savings. And this is study, I don't know if you can see where it came from, but it was done in China. You would never be able to do that study here because the prospective randomized trial would cost you $2,000 a patient for a drug that's worth $1.50. No one's going to fund that trial. But the reality is if you're going to take an economic approach based on the available data, this is an easy substitute to place in your care plan. So this is my simplified ERP. I highlighted what I think are the newer approaches. I'll talk about why the selection of the analgesics at the end of the talk. But it's really a pretty simple strategy. And when you pick off things that I think are standard, if you're doing all open surgery, no matter what kind of enhanced recovery program, you're never going to be as good as a group that is blended minimally invasive and open. Because minimally invasive leads to an improvement in outcome for the population managed that can't be achieved without some portion of patients having minimally invasive and some still requiring open surgery. So I let in about anemia, and this just shows what the impact of transfusion is. You can argue how big or bad it is, but if it was you, generally you would choose not to be transfused if you didn't really need to be. And so if you can predict up front that a patient is already anemic, it doesn't give you much margin for even a well-done operation. So why not try to see if you can improve that before you do it? So yeah, we have to go back to doctor school and remember some of the blood tests that you do to identify what kind of anemia it is. But really, if you want to keep it simple, it's only the CBC. If the hemoglobin's low and the MCV is low, you could almost bet it's going to be iron deficiency, and you can, maybe consult somebody if you can't handle it from there. But we did most of this by reflex testing because you can really do that. And the goal is to make it seamless for the patient, that they can get into the infusion center right away and get their infusion done. And you can make a significant increase in hemoglobin even in 10 to 14 days. So it's a really safe and easy way to do it. And this, you don't have to read the eye chart, but there's a couple of strategies. There's several different products. Each has its own relative merits. You can choose as a system, and some ideas it's a cost issue, which product to use, but they're all probably equally efficacious in reversing the anemia in a time-constrained fashion. So let's talk a little bit about immunonutrition. So we have to decide what really is the goal and when were these studies done. So I'm going to show you several of the more recent studies done in the modern time, right, with modern surgery, good percentage laparoscopic, some bowel prep, some not, so that hasn't been standard, but at least closer to this. So I will tell you that surgery was very different in the 80s. It was a lot more invasive. For a lot of reasons. I mean, I trained in an era where you didn't take the NG tube out under penalty of death for 5 days, no matter what. Didn't matter what was going on. If the bowels were working, they weren't working, it didn't matter because we were protecting the anastomosis for 5 days. That's clearly very different than what we do today. And so the stress of the surgery was very much different, so I'm not sure the data from then applies, and we also understand the physiology much better. So this is the first of a couple. This is from Europe. Basically showed really no difference in infectious complications. Another larger study looking at equal protein calorie Supplementation, this was an ICU trial, so you could argue, sicker folks than we might see with elective surgery, but still gives guidance that this typical prep of arginine, glutamine, and omega fatty acids didn't make a difference in SSI. And the reason is none of those things actually drive immune function based on current science. And in fact, several of the recent prospective randomized trials with glutamine in it actually showed negative results with increased toxicity, particularly renal failure. So the science from, again, 30 years ago doesn't apply. And you have to have always meta-analysis here just to show the little boxes. But the take-home message is that really no difference. Yes, giving calories does matter, but the current commonly studied immunonutrition products don't work. This is one where you have to read the paper and read several papers. So I'm going to make no value judgment on the discussion. I'm just going to walk you through the sequence of publications. So this is the same group, same authors. These papers you can see when they showed up, 2016, and a month later in 2016. It went from 128 to magically 256, and that's a pretty easy math to do, that's double the patients. When you look at comparing the data, all of the statistical significance came out of the first study. The patients they added in the next publication, it still maintained some statistical significance, but the second group wasn't significant as a population. If you'd have done that 128 against the other 128, there would have been no difference. So one would have to wonder what was the real timing of the data accumulation and analysis and whatnot. And so, in this day of easy publications in less stringent journals, you can get multiple things on the same topic that may confuse your ultimate conclusions. So this is why I don't think the data works. So this, unfortunately, doesn't exist much in our literature other than some of the studies showing that if that have looked at sarcopenia as a risk factor, but rarely does our literature look at the treatment or the physiology of sarcopenia. And the physiology is very different. Few of our patients in the US are truly protein calorie malnourished when they come in. What they are is sarcopenic. And this physiology is unique because to reverse it takes specific elements. It takes leucine predominantly as the amino acid, takes vitamin D to drive the process, and supplementation directly with arginine doesn't work because when you take enteral arginine in, 60 to 80% is broken down on the first pass through the liver. So it's not pharmacologically available to the system when you give direct arginine. That's why a lot of the direct arginine studies have failed, as I showed you in those earlier studies. So this is the work you're probably more familiar with. This is sort of the CT morphometric analysis for sarcopenia. And what it really shows, because you can't probably walk through a ER without getting a CAT scan for some reason, that we have a tool that's pretty readily available to decide who's sarcopenic or not. And if you're old on the CAT scan, you're just old. But if you're young on the CAT scan, you may not be as infirm as everybody thinks. So to use that tool more efficiently to think about who to stratify for more vigorous supplementation. And when you look at the sarcopenia literature, if someone's sarcopenic on a CAT scan, you can make a 3 to 5% improvement, but it takes 4 weeks. You're not going to give 3 days before surgery and reverse that physiology. It makes no sense. That's why a lot of these studies with 3 or 4 days of supplementation, having a large group who are probably retrospectively sarcopenic, failed to show a significant difference because neither of the preps that they were using to replete actually repleted pharmacologically the way you need to fix the problem. So, if you would have read this other science, which unfortunately is in the geriatric literature largely, you can come up with a much different conclusion of what products you might use. And that just shows the cost outcome of sarcopenic versus not. It comes back, again, this is a strategy that we don't typically think of in terms of administration. Yes, this is stuff that has to be fixed pre-admission, but all the penalty to the patient and to us comes after the admission. So if we're going to take all of that misery, both of us, the patient and the providers, we have to intervene at a time where we can do it and should really be part of the bundle of care. If you're really thinking about a bundled strategy, fixing that sarcopenia up front may have much more of an advantage than anything else that you're doing right now, intra-op or post-op. So this just shows, this is the largest randomized trial looking at repair of sarcopenia. Again, this is mostly from our medical colleagues, but it really shows what it takes. If you give vitamin D and a leucine-enriched protein, you're going to have a much better advantage. If you give some of the other supplements that are high carbohydrate and really not refined amino acids, you're really not going to make any benefit in their physiology. And just to review for students in the room or the younger residents who are closer to the biochemistry, this is where arginine goes, and arginine gets used a lot of ways that we need for surgery. Not only immune function, it supports endothelial function to decrease acute kidney injury, to decrease cardiovascular complications, for wound healing because it gets turned into proline. So you need to have systemic arginine going out to those end organs to be functional. Just giving arginine by mouth and having it being broken down before it's ever used is not an effective way to do it. And glutamine, if it does work, although the data would be a little specious right now about glutamine supplementation, it works by becoming citrulline, which then becomes arginine. So you really have to go back and understand that biochemistry that we long forgot to decide how, again, to evolve your care plan. And you can see the pictures. It tries to show the different organs. But the advantage of citrulline versus arginine is it's almost 100% absorbed by the GI tract. It's almost 100% converted to arginine by the kidney that then goes from the kidney through the veins to the heart and from the heart out to all the end organs as functional. So you're a much higher bolus of arginine for a given dose of citrulline than you are giving arginine to try to supplement it. And so again, most of our supplements that we have in hospitals are high in arginine, which is unlikely to be effective. And you don't have to look at the little star, where the little stars are. I'm happy to share this data with you. These are the end organ functions of arginine, what it becomes active, what amino acid in what organ system. And you can see that with citrulline supplementation, you significantly elevate those end user molecules for each of the organs. Skeletal muscle, kidney, cardiovascular are much better supplied by citrulline than they are by arginine. And this just shows that head-to-head, if you give citrulline, you get a much better response systemically than an equal amount of arginine. And arginine is limited by toxicity, because if you give higher doses, you can get GI toxicity, diarrhea, and cramping. Citrulline, honestly, at all the studies levels, has never shown any toxic amount. I'm sure there's a theoretical maximum amount of citrulline, but in the amounts that are given pharmacologically, there really hasn't been a toxic dose identified. Let's switch to carb load, because it's really a bad term, because it implies a whole bunch of things that really aren't the goal. You're not preparing for a marathon, so you're not trying to increase muscle glycogen. That is not the story here, and it's not nutrition before surgery. What it is trying to reduce whatever component of stress-induced hyperglycemia you as an individual are at risk for. And if you look at a population, this is the same analogy as DVT prophylaxis. Even if you don't give heparin and you do an operation, not everyone's going to get a DVT, right? It's a population rate that we treat. It's the same thing here. Only about a third, depending on the operation. The bigger the operation, the higher the response. But in general, most general surgical procedures, it's about 30 to 40% of the population that is at risk to develop hyperglycemia from stress induction. So not everybody will. So if you're not going to look at the population outcomes or the population level of hyperglycemia, you're going to miss the benefit of the strategy. But what this data shows, that non-diabetics have a rate of about 30% to be greater than 140. If you go greater than 140, you triple the rate of a variety of complications, most importantly SSI. But you increase your AKI rate and you increase your cardiovascular complication rate. So most of us, I wouldn't have ever, I still don't treat a glucose of 160. I assume it's going to come back in a normal patient, and I don't want to risk the hypoglycemia event. You know, I'll treat 300 obviously, but we're not going to chase those small levels. But the problem is we generally ignore those small levels, and if you look at large data sets, those levels of 140 and above have significant impact at the population level that you're managing. And this just shows, again, the little bump of the control group versus enhanced recovery. A little more sophisticated way to look at it, the HOMA-IR is one mechanism or one test to prove insulin resistance. And you can see the bump maximizes on post-op day 0 to 1. And then if you don't have a complication, you'll return back to your normal physiology over the next couple of days. But it's that first bump that gets you the complication rate. It is reversible generally, but it is generally preventable. Type 2 diabetics, unless really severe, do have a same bump. It's interesting that the outcomes are worse in a non-diabetic who becomes mildly hyperglycemic than a diabetic who does. Probably because we're a little more aggressive in treating them as well, and we might treat more aggressively a diabetic up front. But still, the non-diabetics fare much worse. And if you look at most surgical populations, 80% are non-diabetic when they come in. And it's a dose response for hyperglycemia. It's a paper from the Cleveland Clinic Ravi Kiran did, and you can just see all the 0.001s are bad for everything when you become hyperglycemic. There's a whole cascade of complications that ensue. Now, this is not like an 80% rate of complications, right? But it doubles or triples your native rate compared to people who don't become hyperglycemic. So these are the various carb loading options that are out there. And again, you have to kind of look at the science. But this is probably one of the studies that you may have missed. This is the ProSci study. So this would be the study for all of the products that are 50-gram maltodextrin. And what it really shows is that the population rate of hyperglycemia did not reduce sufficiently. It reduced compared to water. It dropped it by about half compared to just doing water overnight. But it didn't reduce it enough to decrease the population rate of complications. So it dropped it to about 24%. That population rate of 24% isn't much different than what I told you is the native rate of hyperglycemia post-op in a non-treated population. So it really didn't mitigate sufficiently that insulin resistance that occurred in this population to change the outcomes. Conversely, looking at a half the dose, 25 grams, this dramatically changed the rate of the glycemic variability from 20%, which was, in this group it was Gatorade, but not much different than the 50-gram maltodextrin, dropped it to 7%. So you really have to drop that population rate enough to be able to get the benefits in terms of hyperglycemia. I already talked about citrulline, but one other advantage of citrulline in the liver is that, because it's being investigated now if there's bariatric surgeons in the room, it's being investigated now in terms of NASH to try to mitigate the impact of NASH, but it decreases in the liver gluconeogenesis, which is, again, one of the stress responses to the stress of surgery. So if you can drop that gluconeogenic rate, you're going to have a lower rate of, again, hyperglycemia from endogenous glucose production. One other thing, this comes more from the cardiovascular literature, but the arginine ADMA ratio, ADMA is asymmetric dimethyl arginine. It's a natural inhibitor of arginine functionality. That ratio describes endothelial function. So if you want to do fancy tests to assess endothelial function, the lower that ratio, the worse the endothelial function. That leads to kidney injury and cardiovascular complications. This data is from an unselected group of patients in an enhanced recovery program, no supplementation, and it shows about a 20-25% drop in that ratio. If this were an ICU population where it's been studied better, this would tie directly to increased complications. And this just shows some of the ICU data, and you can see it's almost a linear relationship for both infectious complications because of the arginine impact on immune function, as well as the cardiovascular complications because of the endothelial function story. It's almost a linear relationship as that ratio drops. Also, there have been several publications about the increase in AKI. Again, this is generally reversible, but a percentage do end up on dialysis or with permanent renal dysfunction. This is from Hedrick's group. But basically it shows about 12 to 14% rate of some degree of acute kidney injury, again because of this endothelial function issue, made worse by hyperglycemia. So these are, again, you're tweaking this. So this is reversible. Typically we would ignore it, right? But it does change your care plan because most of us, if your creatinine bumps, would now say, I'm going to withhold the NSAID. So now you've degraded your care plan for analgesia because of a complication that may have been preventable. So it does have a cascade of events that impacts your enhanced recovery program even beyond the fact of the renal function itself. The other thing that's out there is a troponism issue. This is work from Cleveland Clinic with Sessler. This would be the bump in troponin that we end up probably consulting cardiology, and then we get confused, is it a non-STEMI or not? But the reality is, if you look at the data, 93% of these people had no EKG change, had a bump in troponin, and had a significant increase in short-term and long-term mortality. Again, this is because of that stress response with impaired endothelial function post-op. And the rate is about 3% in a surgical population. So, much higher than our rate of DVT prophylaxis, which we've all been trained to jump on regularly. So this rate is much higher than that, and generally something that we would ignore and hope gets better on its own. Let's talk about intraop fluid management. So this data gets a little more complex because it's sort of like the Goldilocks thing, right? You want to be just right. You don't want to be too wet. You don't want to be too dry. And the problem is that under anesthesia, there's really no way to figure out too wet and too dry. The data they rely on is very difficult to monitor. And so I think generally the take-home message is that you need some tool beyond a blood pressure cuff and a straight art line to be able to assess intravascular volume so that you can adjust the fluid management for that patient. And the goal is to figure out if they're fluid sensitive or not. So people use various strategies. Stroke volume variation is a common one. But it's an easy tool to do. These aren't expensive devices. And importantly, they have now devices that are minimally invasive, that don't require an art line, and that you can carry over from the OR onto the floor. So that now the fluid strategy doesn't get reversed. Not that you folks would ever do this, but at 2 in the morning, when the intern gets called because the urine output's a little low, you don't give a liter of saline. You ask first, are they fluid sensitive, yes or no? If they're fluid sensitive, you may give a bolus. But if they're not, you wouldn't necessarily bolus the patient post-op and undo the fluid management that was tried to achieve in the operating room. What this data shows also is how precarious changes in the blood pressure are. So in this study, the INPRESS study, they tried to maintain the blood pressure 10% of baseline with pressors. Now, I come from an era where when, as a surgeon, I hear they're using pressors, I'm saying, no, you need more fluid, and you're out of control. If you look at the data, actually, this shows that population that is not fluid sensitive anymore and does benefit from a pressor. And you can see the significant difference. The yellow curve is standard treatment, a much higher risk of mortality and cardiovascular complications for what would generally be a generally tolerated drop in blood pressure of 10%. So tighter blood pressure control intraop with appropriate fluid management is probably the order of the day today. This was the Fedora trial, also a similar thing, guided fluid management. They used a device to guide their stroke volume variation assessment, and again, a significant improvement in outcomes. And this was not a sick population. This was a very typical, not unwell population of colectomy patients. Let's talk about post-op bilious. I talked about that earlier. I know you guys are already very aggressive on the minimization of narcotics because post-op bilious is about a 90% narcotic problem and not all the other things that we were trained as surgeons to blame on post-op bilious. So there are numerous risk factors, but whenever you look at it, the prevention pharmacologically of the ileus, if you're in a paradigm of giving narcotics. So for me, most of my laparoscopic patients see zero narcotic during their hospitalization. So I don't prophylax that population because I know my risk is very, very low, and not everyone that gets a little bit of narcotic is going to get an ileus, so I don't treat those. But I know my bigger open cases are for sure going to get narcotics in some form, so I do prophylax them because there is a reproducible rate of about 15% for post-op ileus in that population. And so we'll switch gears now because this ties directly to analgesia. Fortunately, we've evolved back to we can actually try to manage the pain effectively and not have it be a vital sign as it has for the last decade. But there's a lot of misadventures that go with poor pain control, and I think that should be the focus today. It's not so much what meds you use. If you're getting effective analgesia, you're going to mitigate these complications. It's the combination of larger doses of drugs you really prefer not to use and still poor pain control. And there's probably some reasons why that occurs. So this is a slide, the heroin epidemic and fentanyl issue is in the news every night, but it just shows you the transition. In the era before I trained and when I was a resident, you got to narcotics the good old-fashioned way, right? Street drugs. Now, most patients get to narcotics because they start with a prescription. And they get mismanaged pain, and they end up on narcotics long term. And that really is sad. You know, there you can argue about all the reasons why that occurred, but clearly we recognize this is an issue, and this is a focus on better pain control overall on how we manage our patients. This is unfortunately still the way, I think you guys can tell me, that they teach it in medical school. This is the way I learned it. And this is the way it goes on call, right? You get a call, Mrs. Jones still having pain. All right, let's bump up the drug. Let's double it. Oh, she's still having pain. Let's triple it. Oh, it's a rapid now because she's not breathing, so we'll take her to the ICU. It really isn't this strategy. What you need is a strategy of baseline narcotic sparing that's scheduled with some version of rescue therapy if the pain is really not being managed at that level. That's a very different approach because you'll need less rescue drug if you have a baseline level of analgesia. I abandoned Epidural probably 17 years ago after we did a prospective randomized trial when I was at the clinic. I think it generally has come and gone. It was really pushed in Europe. Interestingly, Henrik Kaled, who honestly deserves the credit for being really the father of a lot of this work, this was the only thing, and he's a pretty rigorous guy, I got to tell you, and a really honest guy. This was the only thing he would never submit to prospective randomization because he knew it was definitely doing God's work to do the epidural, so he didn't want to abandon it. But turns out even someone like that can get blinders. And so again, more data here about no epidural, especially in laparoscopy. It just increases length of stay and is not a superior way to deliver analgesia. This, I think, is pretty slick. I routinely do tap blocks. So laparoscopically, I do my own because it's really easy to see. And I do a 4-quadrant tap block. Tip of the 9th rib, top of the triangle of petite, bilaterally. I still use regular bupivacaine or ropivacaine, whatever is available at that time. And I just do whatever the maximum dose I can use divided by 4 and inject it myself. For my open cases, because I can't get that far laterally safely, in the operating room, I have anesthesia do it under ultrasound guidance. I think this is a huge advantage for post-op pain management. It just shows some of the data in terms of tap block outcome, in terms of being able to discharge people as early as post-op day 1. So let's really change gears and go deep science now for things that nobody's looked at in a long, long time. So we now have science to know how some of these genes work. And they matter because they change how you metabolize drugs. So the reason that the black box warning is on codeine cough medicine for kids is that the rate of that mutation in the African American population is 20%. And they're rapid metabolizers. So they take that codeine and it goes directly to morphine and they stop breathing. So if you think about that, if you're doing genetic testing, that's great. If you don't have genetic testing, why would you ever want to use a prodrug? I'm going to leave you with that message and show you, unfortunately, what we do. But these are the different genes that impact, and I'm going to sort of walk you through a strategy, not that you need to memorize the genes right now, but there is a strategy to just guess on a safer, what I think is a safer protocol, and then scale up if you need to. So in the literature, there's a risk of NSAID leak, and we believe that it causes bleeding as well as surgeons. And it turns out that's probably right, but for a different reason than we think. It may not be a class effect. It may be a side effect of someone with a gene mutation. So all of the NSAIDs except for naproxen, COX-2s included, are metabolized by either CYP2C8 or 2C9. If you have one of those mutations and you take a typical dose of a drug, you could have a 9-fold higher systemic level of that drug than anybody would think. Naproxen, because it isn't impacted by that, whatever dose of naproxen you give is the dose of naproxen. So you're not going to have any of that risk. So if it's a class effect of NSAIDs, that'll be a challenge for us. But I think that you certainly avoid a potential toxicity that you can't prove because you don't have that testing available clinically right now. And so I think in the leaks, not that it's been studied excessively to that level because a lot of people don't use naproxen. Naproxen has really never been included in a report with anastomotic leaks, whereas virtually every other drug has been included. And so everybody tells me to use a COX-2 because that's really safer. Unfortunately, actually, it has a black box from the FDA and a conclusion that a detrimental effect of celecoxib on anastomotic healing is suggested and requires further evaluation. So I'm thinking I really don't want to be the one doing the prospective randomized trial. I'd rather just not use it because I don't really want to worry about what the risk is or isn't. And this came from that study. And what it shows is that 20 to 25% of the population has a mutation that impairs NSAID metabolism. Again, we don't routinely test this, and we unfairly blame it for kidney function and bleeding and a variety of things. But you will not have a good pain management program without using NSAIDs as a significant part of that. So if you're going to preclude it because you either caused the renal failure because you didn't load the patient the right way, or you chose a drug that they can't metabolize, you're not going to degrade your care plan. Not your fault. You just could have prevented the ability to not do that. And this just shows the rate of almost 25% for a poor metabolizer. So if you look at a strategy to do this, if you were able to do these tests, and I'm not going to ask you to memorize the genes, and it probably hasn't made it to that little January quiz that you guys take yet, but it probably will eventually. But if you could know these genes, you would make these changes in your care plan, right? You would change to naproxen if you knew you had a CYP mutation. If you had a CYP3A4 mutation, you'd avoid almost all the narcotics. And in this case, I would never use tramadol because it doesn't work at all. If you look at tramadol, which I think are trained to believe is safer, it's probably the most risky drug because it can go 4 different ways. It can become an antidepressant and never be an analgesic. It can go really directly to active drug and you get side effects. It's really slow to active drug and you don't get analgesia, or it might work. So for me, that's way too much to remember about which way it's going to be. And so I think you probably will know in your own world, your people on tramadol are saying, hey, it doesn't work for me, it hurts. They're probably right. It really doesn't work for them. So as you walk through these, there is a strategy to do this, but I'm going to show you a little more simple way to think through this. The other thing I give is gabapentin as part of my routine. It's cheap and consistently effective in 2 ways. It probably has some mild benefit in acute analgesia, but it has a real benefit in reducing chronic pain and duration of narcotic consumption. So if we're looking to a transition of minimizing the impact of narcotics, get them off of that more quickly, that's the role that adding gabapentin does. I can't tell you that it's 30% better for acute pain management. I don't think that's true, but it does have some other advantages, again, as part of a global analgesic program. And this is just a recent study that was in JAMA Surgery earlier this year, and it showed that there was a significant reduction in the time to opioid cessation for the group on gabapentin. So again, a little different reason to think about using it, but again, if you're thinking about enhanced recovery, we want all the components to actually enhance the recovery and play some role in that process. Unfortunately, this is what we all prescribe, Norco, right? So you take a prodrug and you combine it with another drug, so you can't really maximize the Tylenol dose because you're kind of capped on that based on what choice you made on your Norco. Now you're hoping they can metabolize the Norco to become what? Dilaudid. Why not just give them Dilaudid for real? If you really want them to get Dilaudid, give them Dilaudid straight up. And the reason that Dilaudid is a good choice is it's metabolized by glucuronidation in the liver, so it is almost immune to any of the mutations in terms of dysfunction. Plus, it doesn't have an active metabolite like almost all the other narcotics, so you can't stack the drug. Right? If you give morphine, you can have morphine, and then you have an active metabolite plus more morphine, and that's why you get the rapid call 4 hours later, is you stack this medication on the patients, whereas Dilaudid can't stack and will be excreted by the kidney and by the liver, so you, again, can't have more drug on board. So if you were going to order one of these tests, this is kind of what it looks. It comes in surgeon terms, green, good, everything not green, bad. So you don't really even have to think about it. You can just see what's on the green list. In this case, tramadol was okay for this patient. But if you didn't have access to this, and unfortunately it isn't really quite ready for prime time, I bet we are here in 5 years or less, because the FDA now is actually mandating that when you come with a new drug, that you describe the metabolic pathway. So you can say, what is the impact of someone's rapid metabolizer or a slow metabolizer or whatnot in terms of what your labeling will be for your drug. So I'm going to tell you, you can pick and choose what you want, but it's very easy when you have your enhanced recovery. You should pick what you think you're making better, and you should be able to monetize how much better that is. Not only just the outcome for the patient, but what is the cost of it. And so if you walk through the different issues, so anemia evaluation allows you to treat it before you come in, avoid the negative impact of both cost and outcome of a transfusion. You should, as you think about your care plan, you should a priori define what it is you want to measure that describes the benefit of using that thing. And if it turns out that it's cost effective, it should be in your enhanced recovery program. And if you magically don't have that complication, then you might not need that part of your care plan. But at least it gives you a strategy of how to build one and evaluate on the fly what is the next thing to either add or supplement. So to look at this, if we were a business, a direct bundle to the patient of these things that seem like they're evidence-based is about $80. In hospital, it's about $9 for the cheap version of the IV prophylaxis. Ileus prophylaxis is probably the most expensive thing we as surgeons order because that pill is expensive. But again, I only use that for the group that's going to have a high exposure to narcotics because that's what it fixes. The narcotic-sparing analgesia is budget dust, right? And early feeding ambulation should cost you nothing because they're already here at the hotel. So there's no added cost. So when you put that in, it comes to about $110 on a $24,000 item. If we were building a car, we would say, yeah, put it on all day. It is not much, it's a little glitzy, we can sell it a little better. It's not really costing us much on the product. And it's amazing how much administration will fight about short dollars. But if you get AKI because they got hyperglycemic, that costs you 5 days in the hospital. So that's about $2,000 a day of extra stay. So one patient out of 1,000 with AKI pays for the drug for the 1,000 patients. So if you start to monetize things that way, it becomes a lot more efficient. And this is from the University of Cincinnati group. They actually rolled this bundle in. They provide it directly to the patient, and it shows that they had significant improvement, reduction in length of stay, reduction in a whole variety of complications, and importantly, they save money. It cost them less to do the bundle and roll it in and standardize their care plan. And you know, I've been on a lot of these committees for enhanced recovery, and it's amazing how much religion comes into the debate when a lot of this is really simple science and really easy to prove financially. It really shouldn't be that big a discussion about I like this and you don't like that, and it isn't about like. It really is about, can we prove a problem? Is there a way to mitigate that problem, and does that mitigation make sense? So I would take the CAUTI money and put it all in enhanced recovery, because that would be a much more efficient way to use the money. So I'll stop here, and once again, thank you for the kind invitation, and be happy to take questions.
Very much, Tony. Excellent review. George?
Actually,